All right, let's jump straight into this explainer on thyroid disease for USMLE Step 2 CK. We're focusing heavily on next best step decision logic and strict lab interpretation, tracking the clinical evaluation from the very first presentation right down to targeted therapies. We've got a lot of ground to cover today. We're going to hit initial TSH screening, move through the hyperthyroid pathway, tackle thyroid storm emergencies, look at pregnancy caveats, trace the hypothyroid pathway, and finally, break down the thyroid nodule algorithm. Starting off with Section 1, Initial TSH Screening. Think of this as the fundamental branch point for absolutely any suspected thyroid disorder. So, the very first step for any thyroid evaluation, you're going to measure TSH alongside free T4 and 3. This is crucial to distinguish between primary and secondary disease. A low TSH with a high free T4 or 3, that means primary thyrotoxicosis. On the flip side, a high TSH with a low free T4 points to primary hypothyroidism. And if you see a high TSH but the free T4 is totally normal, that's subclinical hypothyroidism. Now, here is a massive rule for the exam. Do not image the pituitary or the thyroid before you actually confirm this biochemical pattern. The only exception is if the question explicitly describes a palpable nodule that needs an immediate ultrasound. Moving on to Section 2, let's look at the hyperthyroid pathway and radioactive iodine uptake differentiation. Radioactive iodine uptake, or RAIU, is brilliant because it neatly divides hormone overproduction from hormone leakage or exogenous intake. If the uptake is high or normal, the thyroid is actively churning out hormone. This points you straight to Graves' disease, toxic multinodular goiter, a toxic adenoma, or even functioning metastases. But if the uptake is low, that means the hormone is just leaking from inflamed tissue, or the patient is taking it from the outside. Think painless thyroiditis, subacute decurvain thyroiditis, or exogenous levothyroxine. And remember, because thyroiditis just causes a transient hyperthyroidism from preformed hormone dumping out, antithyroid drugs won't help at all. You've got to use beta blockers for the symptoms and NSAIDs for the inflammation. Now, for Graves' disease specifically, your next best step treatment choice is going to branch into either antithyroid drugs, radioactive iodine, or surgery. The right answer completely depends on patient specifics, like whether they have ophthalmopathy or if there's a suspicion of cancer. You'll easily spot Graves on the exam by classic findings: heat intolerance, weight loss, tachycardia, lid lag, proptosis, and pretibial myxedema. If your patient has mild hyperthyroidism or they're in their first trimester of pregnancy, you're definitely leaning toward antithyroid drugs. But what about radioactive iodine? Well, a highly tested and frankly expected complication of radioactive iodine therapy for Graves is permanent hypothyroidism. Because the hyperactive gland takes up the radioisotope so diffusely, the tissue destruction is extensive. It's also super important to note that radioactive iodine can acutely worsen ophthalmopathy, so it is contraindicated in patients with severe eye involvement unless they are pretreated with glucocorticoids. You also have to differentiate amiodarone-induced thyrotoxicosis into two distinct types. Type 1 acts a lot like iodine-induced hormone synthesis. You'll see increased vascularity on an ultrasound, and you treat it with antithyroid drugs. Type 2, however, is a destructive thyroiditis. It shows decreased vascularity with an undetectable radioactive iodine uptake. For type 2, you're going to treat with glucocorticoids to calm down that destructive inflammation. All right, on to Section 3, Thyroid Storm Emergencies. Let's look at these high acuity presentations. If you see a question with postoperative high fever, tachycardia, hypertension, and lid lag, that points directly to a thyroid storm triggered by surgical stress or an iodine load. It could also be triggered by acute illness, trauma, childbirth, or a severe infection in an untreated hyperthyroid patient. The treatment sequence here is heavily tested, so lock this in. Start with a beta blocker to control the heart rate, then give PTU to block synthesis and peripheral conversion, follow that up with iodine to halt release, and finally administer glucocorticoids. And you absolutely must differentiate this from malignant hyperthermia. On the exam, both a thyroid storm and malignant hyperthermia can show up postoperatively with a high fever and tachycardia. But if the vignette describes rigid muscles, hyperkalemia, and a CK level in the tens of thousands, you are definitely dealing with malignant hyperthermia, not a thyroid storm. Next up is Section 4, Pregnancy Caveats. Pregnancy completely alters the thyroid hormone baseline, which means we need strict trimester-specific parameter adjustments. Here's what happens. Beta-HCG actually stimulates the thyroid follicles directly. This leads to increased T4 and T3 production, which causes a normal physiologic suppression of TSH. Estrogen is also at play here, increasing thyroxine-binding globulin, which elevates the total T4 and T3 levels. So if the TSH is markedly suppressed below trimester-specific norms, you've got to confirm that hyperthyroid state by checking a free T4 level. Also, just keep in mind that gestational transient thyroxicosis from high HCG usually resolves entirely on its own as hyperemesis gravidarum gets better. When it comes to treating hyperthyroidism in pregnancy, teratogenic risks dictate your next best step. Always select PTU for the first trimester and then strictly switch over to methimazole for the rest of the pregnancy. You have to be careful, though, because overtreatment can cause fetal hyperthyroidism. The clinical goal here is actually just to maintain a mild hyperthyroid state in the mother. Now, what if the patient is hypothyroid? The exam-facing next best step for a hypothyroid patient who gets a positive pregnancy test is an immediate 30% increase in their levothyroxine dose. Since pregnancy bumps up that thyroxine-binding globulin, the body's requirement for L-thyroxine jumps significantly right away. You need to measure their TSH every 4 weeks and adjust the dose to make sure it stays within those strict trimester-specific norms. This is critical to protect fetal neurodevelopment. Let's pivot to Section 5, the hypothyroid pathway. Primary hypothyroidism is classic: fatigue, cold intolerance, weight gain, constipation, delayed reflexes, and it's simply treated with levothyroxine. But what happens when those labs are borderline? That brings us to subclinical hypothyroidism, where you have an elevated TSH but a totally normal T4. You only treat this with levothyroxine if the TSH is over 10 or if anti-TPO antibodies or specific symptoms are present. If the TSH is mildly elevated, so somewhere between normal and 10, look for things like a goiter, symptomatic presentation, pregnancy, or ovulatory dysfunction with infertility. If all of those are absent and anti-TPO antibodies are negative, your next best step is simply routine monitoring. Don't rush to treat. You also need to recognize euthyroid 6 syndrome. This is a transient, maladaptive central hypothyroid state that happens during severe illness. Peripheral conversion drops off, which gives you a low T3 but an elevated reverse T3. Early on, the TSH and T4 might actually look completely normal. The huge takeaway for the boards here is that this requires absolutely no treatment. Do not give these patients levothyroxine. You just wait for them to recover from their primary severe illness and only reevaluate the thyroid if those abnormalities persist long after they've recovered. Finally, we wrap up with Section 6, the thyroid nodule algorithm. This is a highly tested, step-by-step physical examination branch point. Always start a nodule workup with a TSH and a thyroid ultrasound. You only proceed to a fine needle aspiration, or FNA, if scintigraphy proves the nodule is cold or indeterminate. Basically, if the TSH is low, order a radionuclear scan. Hot nodules are rarely malignant, and you can usually just treat them for hyperthyroidism. But cold or suspicious nodules on ultrasound, those require an FNA. And if that FNA reveals cancer, you need to know those subtype clues. Papillary cancer is the most common and spreads via the lymphatics. Follicular cancer spreads hematogenously. Medullary cancer arises from C cells and you use calcitonin for follow-up. And anaplastic, that one is highly aggressive. To close this out, you have to memorize these exact indications for a thyroidectomy. Discovering a cold nodule on a scan that yields suspicion of cancer on an FNA will immediately mandate surgical resection. You'll also select surgery for a very large goiter, a retrosternal goiter with obstructive symptoms, or severe Graves' ophthalmopathy where radioactive iodine is strictly contraindicated. And remember, after surgery for differentiated thyroid cancer, serum thyroglobulin is exactly what you use as a marker to monitor for recurrence.